Good morning and welcome to the Montana American Cancer Society Cancer Action Network 2017 Policy Summit, The Cost of Cancer, Addressing Patient Costs. And today, since it's Veterans Day, in honor of all those who have served, we would like to thank you on this Veterans Day for all that you have done for our country. My name is Lois Fitzpatrick and I'm the Senior Advocacy Lead. I'm a 22-year cancer survivor. I have advocated on cancer issues for over 20 years, and I have been with the American Cancer Society Cancer Action Network since it began in 2001. We have a really exciting and fascinating day planned for you today. Personally, I can't wait to hear the presenters, because every time I'm at one of these, I go home with so much information and so much excitement that I know everyone's going to come out really charged from this. I also want everyone to know that the Missoula Community Access Television will be filming today's forum. And today we are going to start hearing from some of our senators' representatives. They weren't able to come here today, but Danielle Tribble, if you wouldn't mind coming up. Danielle is from the Senator Daines' office. And I'll share my mic with you, I guess. There.
Take off your collar.
Take my collar off.
Can everyone hear me okay? Okay. So I have a letter from the senator that I would like to read. Welcome to the 2017 American Cancer Society Cancer Action Network Montana Annual Policy Summit. Thank you for inviting me to join you today and allowing me to share a few words. Since 1913, the American Cancer Society has been a leading force in bringing public awareness to the fight against cancer. The Society has stayed true to its mission to saving lives, celebrating lives, and leading the fight for a world without cancer as they offer programs and services across the state of Montana. Tremendous compassion and hard work by volunteers, employees, and partners has contributed to a 25% drop in the overall cancer death rate in the United States, and I commend you for your part in making that a reality for Montana families. As your United States Senator, I remain committed to disease research and providing access to care for those battling diseases such as cancer. Thank you again for inviting me to join you at today's summit. It is an honor to serve Montanans back in Washington, D.C., and if I can ever be of assistance, please do not hesitate to contact me. Sincerely, Steve Daines, United States Senator.
Thank you. And I think we have a microphone now. Yes. And Ricky Henderson is from Senator Tester's office with us today.
All right. Thank you, Lois. Thank you for inviting me to share a few words. Sorry that I am unable to join you today. Every Montana family has been impacted by cancer. It's a horrible disease that can take our loved ones away and change our lives forever. In addition to the health complications, cancer can also take an immense financial toll on a family. That is why I want to thank you all for working together and putting on this important summit. As your senator, I'm taking steps and sponsoring bills to help you in these efforts. First and foremost, I want to thank you for fighting back against the catastrophic health care bills in Congress earlier this year. Besides raising health care costs and kicking families off of their coverage, these partisan bills could have also brought back lifetime and annual caps on coverage, as well as allow insurance companies to deny coverage based on pre-existing conditions. Cancer patients and their families would have been put at extreme risk, and if we hadn't defeated these efforts, moving forward, I am working with both parties on healthcare solutions that bring down the cost of care, increase access to insurance, and protect patients against arbitrary caps on coverage. In addition, I know that family members often become the primary caregiver for a loved one with cancer. I'm co-sponsoring the Credit for Caring Act to help families with that financial burden. This bill will provide a tax credit for individuals who spend money out of their own pockets while caring for an ill family member. By continuing to work together to identify solutions, we can help families with financial hardships that can come with cancer. Please know that my door is always open to each of you. Thanks again for your work. Sincerely, Senator Jon Tester.
Not sure where the off thing is on that. Okay, and I also have a letter from Representative Greg Gianforte. Attendees of the Cancer Action Network Montana Annual Policy Summit. Thank you for inviting me today. I am sorry that I could not attend. It is an honor to serve Montana as lone voice in Congress. The American Cancer Society Cancer Action Network works to improve the lives of those living with cancer in Montana at the local level and nationwide. They take steps every day to eradicate this horrible disease. Their work is incredibly beneficial to many in our state. Watching a family member or loved one battle with cancer is devastating. This year alone, over 2,000 Montanans will die of cancer, and over 15,000 children in the U.S. will be diagnosed with this terrible disease. To stand up for Montana's children that have cancer, I have co-sponsored H.R. 820, the Bipartisan Childhood Cancer Survivorship Treatment, Access, and Research Act. The bill expands opportunity for childhood cancer research, improves childhood cancer tracking, improves quality of life for survivors, and ensures there will be pediatric expertise at the National Institutes of Health. This bill will lead our country down the path to better helping those 15,000 children. I will continue to be a strong voice for those battling cancer in Montana. It is a priority for me to give Montanans the access to health care they deserve. Our health care system is broken. Montanans deserve access to affordable, high-quality health care instead of top-down Washington knows best approach. We need to empower states to be able to make the best choices for their citizens. I will continue to stand up for Montanans as your voice in Washington. Thank you for all the work that you do to help those with cancer and their loved ones. If I can be of help to you or your family, please contact me. Hearing from you and other Montanans allows me to represent our state. I hope that you will enjoy the rest of the Policy Summit. My door is always open. I am here to serve. Sincerely, Greg Gianforte, Member of Congress. Well, a wonderful way to start with our congressional delegation cheering us on, which is what we need. Those of us who work with cancer policy know we need cheering on, so that helps. Just some things going on in your packets. You will find a copy of the Cancer Care Report. How do we measure up, which will give you information on how Montana ranks on state legislative activity to reduce cancer incidence and mortality. Also in your packet are the biographical sketches of all of our panelists today. We have so many of them, we are not going to go through their biographies. So please feel free to take a look at that, especially while they're speaking. At this time, I also want to thank our sponsors. Without them, we would not be having this. A special thanks to our presenting sponsors, Blue Cross Blue Shield of Montana, Bristol Myers Squibb, Pacific Source Health Plans, Providence Health Services, Western Montana, Bozeman Health, AbbVie, and the gold sponsors, Community Medical Center, Kalispell Regional Healthcare, Mountain Pacific Quality Health, Genentech, Jensen Oncology, Sanofi, and the Bronze ARP. So thank our sponsors. Just so you know how the flow is going to be, we have our first panel up here. When they are finished, if the second panel would come up, and please be seated, I will introduce the facilitator of that panel. And that's how we're going to try and move through this and keep on time, which is what I'm going to be doing watching the clock. It is my pleasure to introduce the facilitator of our first panel of survivors and caregivers. Chelsea Rice is our grassroots manager. She is one of our 2 staff members for ACS CAN in Montana. As you can imagine, it's a big job. And so I want to thank Chelsea for doing this. She is a 5-year cancer survivor. And I'm going to let you take it away.
Thank you, Lois.
Is that not on?
We're going to make it happen. Hello? There we go. Thank you so much for coming out today. I'm honored to sit with this panel of survivors and talk about the various costs, both financial and personal, that result after a cancer diagnosis and while trying to seek treatment. With me today is many of our grassroots legislative ambassadors, and I just wanted to give you all just a 2-minute opportunity to introduce yourselves, your name, your role in a cancer diagnosis, and when you were diagnosed and your status currently.
I don't know if this is on.
It might be on.
Okay. Hi, my name is Celeste Thompson. I'm a caregiver, and also I am a 2-year survivor. I was diagnosed with endometriosis in 2015. At that time, I did not have health care, and as soon as they expanded the Medicaid program, I was the first one in the governor's office to sign up for the Medicaid expansion. Right now I'm doing my 6 months checks. I guess that's it.
Thanks, Celeste.
Yeah.
Good morning, I'm Carrie Yoder, and I am a caregiver to my mother, who was diagnosed first with uterine cancer in 2011 and then with breast cancer in 2014. I had to quit my full-time job in 2015 to become her full-time caregiver, spending many days on the road between Helena, where I live, and Great Falls, where she was receiving treatment. So I had to let my career go to begin her caregiving, to become her caregiver. I took over pretty much all of their finances. I had to learn all about Medicare and secondary insurances, and making all those phone calls to make sure that her treatments and everything were covered. It was a learning experience. I'm glad that I was able to do that for my mother, that my husband was willing to be the sole provider for our family. So it has been an experience. I've learned a lot about insurance, and then of course learning about cancer. And then I became involved with ACS CAN 2 years ago, and have become a legislative ambassador, going out and speaking on behalf of cancer patients, families, caregivers, on the policies.
Thanks, Carrie. And don't forget to get a little bit closer. I know the people in back are straining a little bit. Okay. Go right ahead. And feel free to take the mic out if that feels more comfortable.
Hi, my name's Amy Casio. I'm a 2-year breast cancer survivor. And I'm in the cycle now of checks every 3 months, doing really well. At the time that I was diagnosed, thankfully I had healthcare insurance through the Affordable Care Act. I'm an entrepreneur. I started my own business. I had a pre-existing condition, and I had healthcare coverage in place when I was diagnosed at 38. That was incredible to have my care provided for in that way. And I am incredibly thankful and honored to be able to be an ambassador speaking on behalf of others who are navigating these challenges and figuring out how together, it's going to take all of us, how we can make it even better. We're doing some great things, and we can be doing better. So yeah, let's keep doing that.
All right, good morning. My name is Leah Zins, and I am a 4-year survivor. I was living in Mexico, and I came back just thinking that I was going to be here for a few months and moving back, and when I received my diagnosis. And I was unemployed, I was uninsured, and it was a very scary time, as you can imagine. And I had a tumor inside of my spinal cord, so I had to make the decision that to go and save my life and risk paralysis, which is what happened. So, but I am, doing the 6 months checks and everything is looking good. So I got involved with ACS CAN almost a year ago. I've known Chelsea for, like a decade. So I just really admire all the work that she had been doing and wanted to get more involved. And so just thank you for being here today. All right.
And I am also a survivor. As you heard, 5 years. I had a rare and aggressive bladder cancer, likely caused by industrial waste. And I hit my 5-year mark. I think I just said that. But at the time of diagnosis, I was 35. I was an adjunct instructor. I had 3 jobs. And I was not covered by employee insurance. I was denied for a pre-existing condition and had to travel extensively to Mayo Clinic for options for treatment, and treatment that was pretty much experimental. I'm doing well. It sounds like I have a 98% chance that I'm cured, and I'm thrilled to be in this position to hear the stories of others who have survived a cancer treatment, are going through cancer, and care give to cancer patients. So we want to talk about the cost today. I really want to start from, this will be a dialogue. We won't all be able to answer the questions, so I'll ask a couple of you to respond, knowing your stories. And then first of all, before we move into the technicalities of cost, I wanted to ask you about personal cost and what other things beyond the financial cost have been a part of your diagnosis and care and survivorship. And Carrie, I would love for you to speak to this, and then Amy, would you also speak to this? Thanks.
So for me, the financial cost was, giving up my job, but emotionally it was very detrimental to myself and to my family. I was, like I said, working full time. I had been an EMT for 15 years, so you would think that being a caregiver would be an easy job, but when it's taking care of your own parent, it really brings on a lot of emotions that you don't realize are inside. So I had a lot of anger, a lot of bitterness. Wasn't really sure how to deal with all these feelings because I was trying to take care of my mom at the time. So after her going through her chemo and her radiation, that's when everything finally hit me, and I had to learn how to start dealing with those. I was having a lot of anxiety, just kind of pulling away from my friends, my family, my husband at the time. We were in a new relationship, and so it took a lot of emotional costs. Physically, I wasn't taking care of myself. I was too busy trying to take care of my mom. And so, I started having my own physical health problems. Learning to have to take care of myself was a really hard thing. So just learning to take care of myself after taking care of my mom for so many months was it was a big deal. Yeah. So, and then learning to deal with their costs just brought on a whole new, I got a lot of new experiences dealing with insurance companies, financial representatives, something that I don't think anybody thinks about when you're growing up, that you're going to eventually have to become somebody else's financial representative if they aren't able to take care of. So it was really an emotional experience for me.
Thanks, Carrie.
I think speaking to the personal costs, similarly, there was a lot of emotional cost. When there's you're faced with something you don't expect, and you have a certain vision for your life, and then it comes to a screeching halt. I think what I really strive to do through the course of this experience was to make a lot of meaning out of it, and to see the lessons that I was learning and how then to integrate that into my life moving forward. So while I was going through treatment, I was actually in a business partnership with 2 other business partners. And because I am self-employed, I worked full-time through treatment, even days with chemo. I would put in half a day of work. And that, I think in some ways it served me well because I wasn't, I felt still like I had a lot of agency. You know, I had some clients in Bozeman and in Helena, and in those communities, those were ones where I could put on my wig, put on a hat, put on my high heels, drive over, sit in a meeting, and no one needed to know. And that was incredibly empowering. The cost of that was that there wasn't a lot of self-care to really focus on healing. And so it felt like I just put my head down and I just, you know, did it. And then it felt like once I got through this very scheduled course of treatment, which started with, you know, genetic testing and counseling because I have a really significant pattern of cancer in my family, to go through surgery, a lumpectomy, to go through the course of chemo, to go through the course of radiation, to then start hormonal therapy as an estrogen blocker for a prophylactic for reoccurrence. It felt like then I picked my head up and was like, what just happened? Like, what just happened? And now what? Now what do I do? Like, my life is, I mean, it has the opportunity to be really different. And what does that look like? And so it ended up with dissolving my part of the business partnership because I realized these were not partners. And so to be coming through a year almost of treatment and to be essentially starting your own business again, and then to try to figure out a way to put yourself back together and to heal, not just put yourself back together, but to heal. So it feels like we do a great job of kicking the crap out of cancer. We're doing great at that, and survivor rates are up, way up. Where we can do a lot more is in survivorship, because this is for the rest of our lives. And that didn't quite dawn on me of like, oh, it's not just making it through treatment and getting the certificate that you put on your fridge, which is still there. It's like, no, this is actually for the rest of our lives. And how do you heal? And in healing, also be incredibly proactive in your health and really reduce the risks of reoccurrence.
Yeah, I think that it is a great transition into talking about how you cope with survivorship and cope with what is overwhelming. And in particular, I'm thinking about the hardest costs and the medical bills that we have to deal with as survivors and also during diagnosis and treatment. And I'm hoping that Leah and Celeste, that we can both speak to that. And how did you cope or deal with those costs and your medical bills?
Well, if it wasn't for charity care, I wouldn't have been able to pay my bills. Just the surgery alone costed $9,000. But thinking that, I have to pay this and going into debt and more into debt than I already were. But it's just overwhelming with the bills and stuff like that. So, but like I said, if it weren't for charity care, I wouldn't be able to pay my bills. Thank you.
So as I said before, I was totally unemployed and uninsured when I got my diagnosis, and I actually got my surgery out in Portland because no neurosurgeon in the state of Montana had actually done the type of surgery that I had, so don't want to be a guinea pig for that one. I also received quite a bit of charity care it was actually through a Providence hospital out there. And they have an excellent program that allowed me, because one of my bills was like over $100,000, and that wasn't even including the surgery, because I was in the hospital for, in total, just over 2 months. So and that was in part not just because of the cancer, obviously, but like after, you have to learn how to be in a new body and learn how to go through your day being paralyzed. So, yeah, I was completely ready and just had already decided that I was going to like declare like medical bankruptcy, because I was like, well, this is what I need to do. I need to focus on my body. Like I was already like had decided that was going to happen. And fortunately I had just an excellent medical team. My surgeon really like took to me, and he was like, if I could adopt you and then you could just be on my care, then that would be great. So I think he wrote off like as much as he possibly could, because there's no way a 10-hour neurosurgery costs like $5,000. So, so I was really lucky. And then I did end up getting on Medicaid, which took a huge battle. I ended up having to get a lawyer, and it took almost 6 or 7 months for me to be approved. And fortunately, they did backdate some of the treatment, but in that time period, I was having to pay out of pocket for all of my prescriptions and anything like that. And fortunately, I have an excellent relationship with my family. And so when I got my surgery out in Portland, I was there for about 3 weeks or so, and then I was transported to a hospital in Great Falls where my family is. And then when I left the hospital, I was able to go home with them. And so they were able to, if it wasn't for them, I don't actually know what I would have done, because I wouldn't have been able to support myself. I was in this new body. I wasn't able to work. I didn't work for like 1.5 years after. So it's a huge burden. And without the support network that I have, I don't honestly know what I would have done. So.
I wanted to ask you, Carrie, and Leah, were you able to plan out spending when you were working with your mother or yourself as far as medical bills went? Or were bills a surprise, or were you surprised at the cost? And how did you go about managing that aspect of care?
So with my situation, a lot of the procedures, treatments were covered either by Medicare or by their supplemental insurance. So my thing was, as soon as I knew what the next step was, I would get on the phone with the Cancer Treatment Center and call and make sure, okay, is this covered? Is it, are we gonna have to have the second supplemental insurance covered? And so I spent a lot of time on the phone making sure those costs were covered. There was a few incidental treatments that weren't covered. There's like when you have radiation, you have special lotions that you can only use. And so those kinds of things weren't covered, so we had to, figure those costs out of pocket. The driving back and forth to every appointment, that kind of got a little spendy, because she had 35 radiation treatments over the course of 6 weeks, 5 days a week, and it's 50 miles one way from her home to the Cancer Treatment Center. So we had to figure out those costs because they live on a fixed income. So there were some organizations that did help out with gift cards, things like that. So we were able to figure out, but it was really just like staying on top. And I felt like it was the best thing that I could do, because she needed to focus on being taking care of herself. Like, she didn't need to be worried about the expenses, how we were going to pay for stuff, if it was going to be covered. So it was really meaningful to me to be able to do that for her, so she could take care of herself and just rest and get better.
And I don't know if you said this, but you drove often from Helena to Choteau, and then to Great Falls, and then back to Choteau and to Helena. And so the cost incurred for caring for your loved one was also a cost for you.
It was pretty expensive. You know, it's 110 miles from Great Falls to Helena to Great Falls, and then luckily I had family. I could either stay with family in Great Falls or stay with my mom. But it was a burden because we went from a 2 income to 1 income. And so, yeah, my husband, thank goodness, is a very good financial planner and was able to, you know, account for what we were spending out of pocket for those travel days.
So before I actually got my Medicaid coverage, so for those months the main bill I guess I was paying was for medications, which was probably $200 to $300 a month. And I first did like a GoFundMe when I was first diagnosed, and that's what covered those medications in that time period. And then I did start receiving disability payments, so that was what helped me. But everything was kind of up in the air until I got Medicaid, and I was like, I don't know if like that 5 weeks in the hospital is going to be covered. I don't know if my radiation is going to be covered. I don't know if all these other, like going to the urologist, I mean, with paralysis, is a whole host of other complications that are going to be lifelong and that I just have to be on top of constantly so I don't incur life-threatening conditions. And so for me, the stress was more of just like the not knowing of whether I was going to have to pay all of these bills or not. And then having to fight and get a lawyer to get Medicaid was also just a whole nother process and step that I had to go through. So once that finally came through and they decided to backdate it, and I think they did that because there was some bad like press coverage that came out around that time period, and they're like, let's just not have another bad story. So so I did end up getting the coverage, but for that time period I was like, I have no idea how many of these bills I'm going to have to be paying, and I'm not working, and I was working as a teacher in Mexico, so it's not like I was raking it in, but so fortunately during that time period, again, I was able to stay with my parents. So as far as like the basic necessities, they were covered. So in terms of that, I was very lucky. But it all worked out. But it was an incredibly stressful time period, just not knowing.
Celeste, can you talk about the most challenging costs that were not covered by insurance? And Amy, could you also speak to that a bit?
Well, like the pretty much everything that that I had from surgery, low dose of radiation, with the help of Charity Care. But it was money to transportation to get to my appointments, and that just lucky that it was all here in Missoula. But the only thing that when I got Medicaid, they didn't go back to where I have surgery, so I still paying on the bills that my share of the bills. So payments here and there. So, but that's pretty much the challenges that I had. So.
For me personally, the costs that weren't covered are related to the continuance of care moving forward and how we heal in survivorship. So for some people, I mean, I can speak to my personal story, but for some people, it could be a huge lifestyle change. You know, people who, you know, I'm really fortunate in that before cancer, I was really active. I had a really good diet. I had a lot of things going for me. I knew a lot. And I knew that I had a lot of work to do in terms of physical therapy for range of motion, post-radiation. You get a lot of scar tissue. And so continuance of that, really healing your gut, because the chemo really does a number on your, it really targets rapidly dividing cells, which are a lot in your gut health, emotional health. So working with, I think one of the most important things I did was working with a therapist who has had, or she has survivorship training. And how we worked together was coming in and making an action plan. And for me, that was super proactive of being like, okay, in an overwhelming world, let's focus on 4 things. And then like I could set those goals, work through the month on meeting those goals, come back, report, and set new goals. And so that was like one of the most important things for me, I think, of getting my life back on track. And I want to say not just back on track, but growing and learning and evolving from it. And so that these costs in survivorship have not been covered. And so that's, I really see an opportunity for physical therapy, for work around food as medicine, working around emotional health, acupuncture for cognitive. There's a lot of cognitive stuff that happens, and cognitive impairment. And so acupuncture has been incredible about processing, a lot of the toxins that are in your body, and really moving through that cognitive fog through chemo, radiation, and then hormonal medicine. So I think there's a lot we can do. That feels personally really hard to be personally bearing those costs and not having those covered. Again, as a small business owner, those are the things that, the first thing to go when there's not enough cash flow is the acupuncture appointment or the appointment with a therapist. And those are the things that are super necessary and we need moving forward.
And I see you nodding, Carrie, because even as a caretaker, there's a cognitive fog from grief and stress and anger. And I think our loved ones as caretakers also are a part of our survivorship plan, and their care is an important aspect of our survival as well. Cancer brings a lot of things to the surface. I did want to, we have to wrap it up, but I did want to give you all an opportunity to just speak, a couple of lines. What would your advice be to someone who's just been diagnosed and is concerned about finances? Yeah, go ahead, Leah.
I would definitely suggest checking with whatever hospital or facility that you're at and seeing what charity care that they do have, because that's really what saved me out in Portland. They pretty much covered all of my costs because they recognized the state of my finances at the time. So I think that there's a lot of help out there that isn't necessarily like advertised so much with the different facilities. So I would definitely check and see like what the facility has to offer. So
I say two relationships that are really important to have in place. I worked with Helen, who was incredible and became such a friend, to go right to Helen and say, what's going to be covered, what's not going to be covered, and to have someone who's a partner and who is advocating for you and looking out for you, and to come back and say, this is covered. And honestly, Leah, I can't imagine going through treatment with the stress of, like, am I going to be $200,000 in debt? Like, that's the worst thing that someone could be going through when they're already going through a pretty crappy situation. So I think connecting with the billing specialist, where where you're receiving care, and then also requesting a case manager on the insurance side of things, so that you have one point of contact that you can go back to, and you keep calling and saying, hey, this is coming down the pike, and you keep calling, and they start building a file on you, and it's a person who knows your story, knows what's going on, and you start building those two relationships.
So my advice is to not be afraid to ask questions, and keep asking the questions to the providers, to the financial specialists, to the insurance companies. Find the patient navigators at the cancer treatment centers. They have lots of answers. They can always point you in the right direction. And always make sure to have somebody there with you, because when you get that diagnosis, you don't hear another word after. My mom said she just blanked out after they said, you have breast cancer. And so you need to always have somebody there with you to be that second set of ears to make sure that they're hearing exactly what is being said.
And I'll always be positive when you're going through this. And yes, you need to have somebody by you at all times, because you do blank out on what's going on. Thank you.
And I'll add just my 2 cents. In the cognitive fog, I would agree with both of you. Have somebody in the room, your caretaker preferably, and if you can, get a caretaker for your caretaker. Even if that means the occasional beverage. Or just a place to put that energy, because your caretakers shore up too in order to care for you. And what I have experienced is my partner came down with severe suicide after she learned that I would live, which then brought to the forefront the need to stop drinking to cope, which then brought to the forefront a bipolar diagnosis. And so, I mean, the coping mechanisms aren't always positive that your caretaker might need or do in order to withstand the loss of a partner, but making sure that our caretakers have access to care too, and then finally get a big box for all of your medical records and bills and insurance information and keep it organized. We don't have time for questions, but please feel free to approach these folks as you are moving around today, ask them questions, and we really appreciate you having us lend our voice to this important discussion. Thank you.
I want to thank that panel very much. I have to admit, as they were talking, the emotions that went through me, and I'm sure went through you, were staggering. So now turning, we'd like to take a look at the costs through a provider's lens. And the moderator for this panel is Bill Warden of Warden and Associates. He is a lobbyist and a former legislator. And I do want to say in 2017, he was one of our ACS CAN legislative ambassadors. So thank you. And now from the provider's lens.
Thank you. Is this working? I guess so. Okay, thank you. Also had the pleasure to work during the last legislative session on the initiative to pass the tobacco tax, and sad to say we didn't quite get it done, but we got it a long way, so kind of proud of that effort. So I'd like to start. We'll just take a couple of minutes and have the panelists introduce themselves and say a word or two, and then we'll get into it.
Hello, I'm Jack Hensold. I'm a medical oncologist at Bozeman Health. My bio sketch is included in your thing, so I won't go through that. I've been in Bozeman for the last 14 years and have for some of that time spent doing some legislative stuff in the state, which is the first place I met Bill Warden at. My real goal when I came to Montana I was a kind of Midwestern boy and trained in the Northeast, was really to to provide really high quality care so people did not have to leave the state, they could get care close to home. And it's still an ongoing struggle. There are some, I think, Montana-specific unique problems that make that difficult, but I think we're continuing to make improvements in that area. And I think you can be assured that there's much high-quality care that you can get in the state. We've heard some discussions about people leaving, but for most of what you need, you can get it here. But it's an ongoing work to continue and improve that.
Hi, I'm Noelle Butler. I'm a naturopathic doctor with Spring Integrative Health in Bozeman, Montana. I'd love just a quick show of hands. How many people here are familiar with naturopathic medicine? Yay! Oh, good. We've got a great group. So I am trained as a primary care doctor. Naturopathic doctors attend accredited medical schools. We leave able to practice as primary care providers. And I happen to specialize in oncology. And I've been very fortunate in Bozeman that I could very quickly establish myself with Bozeman Health Cancer Center, and they've graciously allowed me to have pretty fantastic relationships with patients in our community, and that's expanded throughout our state. And I've got people traveling from out of state to seek care. You'll see a lot of words like alternative health care. You know, we Americans spend like about $34 billion with a B dollars a year on alternative health care, and you even heard our amazing patients that were here on the panel just before us speak to self-care and the necessity of it along with the conventional medical system. So I'm here to represent what I'm going to call complementary care system, because I really, truly, passionately feel that there's so many providers out there that want to complement conventional care to make sure it works as well as it possibly can, to make sure you're as healthy as you can be going into care, throughout care, and as a survivor. I actually like the word thriver because I want to make sure that on the other side, my patients are healthier than they were before they even started their process. And I think, again, you heard from our panelists prior that hopefully that's their goal too. So I'm here to represent the complementary care as it relates to oncology.
I'm Catherine Borganick. I'm a geriatrician and palliative care doctor in Bozeman. Work with Jack and Noelle, and I've been in Bozeman for about 16 years. I come at this slightly differently, and I was really struck by the previous panel about both the emotional and financial cost to you as individuals, and how, as providers, we don't always understand that piece, and I think it's really key that we need to as providers. So I came across it. So palliative care means what palliative medicine is, that I take care of people as they're going through their disease and even after their disease, to help them with whatever counseling they need, whatever symptom management they need in terms of pain, in terms of treatment from chemotherapy or radiation therapy. I also do a lot of what's called advanced care planning with patients. So sort of looking at what's important to them, not sort of about whether they're dying or not, but what matters to them. There's a great quote out there that I think sort of summarizes what I like to think I do, which is what matters most to the patient is as important as what is the matter with that patient. Think about that one for a minute. I heard that just the other day. I was listening to a webinar about conversations, and I sort of thought, that's really it. That's what I do, and that's what I try to find out for patients as they're going through treatment. I also chair the Montana legislature actually recently approved a statewide palliative care advisory council, and I'm in charge of that. And what we're looking at is what is the state of palliative care across the state of Montana and in the cancer centers. We are in the cancer center at Bozeman 2 half days a week. And we know from the literature in terms of the cancer centers that if you integrate palliative care into cancer centers, that people not only live longer, we can also look at things around better symptom control and indeed even, I hate to say it, some financial impact on taking care of patients with cancer.
Great, thank you for that. And I think we appreciate that first panel, and I want to say, Chelsea, that was a great panel, very moving. So this is a look at the cost of healthcare. So I'd like each one of you to weigh in on what's happening in your particular area of expertise that you think you're contributing to trying to reduce the cost of healthcare. And Catherine, since you kind of went down that road, let's start with you, and you can kind of pick up where you were on that.
So from a palliative care perspective, I think it's really going back to what matters most to the patient. And it may be the latest drug, it may be getting radiation, it may be getting chemotherapy, but we also, it may not be any of those. We have a recent case that patient that I was just dealing with yesterday. She's in the nursing home. She has breast cancer, and she's also got a lot of cognitive impairment. Her functional status is really poor, and we did get a biopsy because her family wanted to know what was going on, and she does have cancer, but she's not going to go any further with that. And for a lot of reasons. There was some thought from within the radiation department that we should be going further and that we should be looking at offering treatment to her, and she was very clear and her family was very clear that this was not appropriate for her. So that's one of the ways that I think we can really be approaching the cost of taking care of patients. What matters to them? What is their functional status? There's some recent data out about frailty and how much it impacts not so much on cancer care, but on surgical care, and that people with a lot of frailty don't do well with surgery. So we really need to be looking again at the whole person and not just what we can offer them in terms of treatment. It's complicated, and Jack can speak to this better than I can because of all the new drugs that we have out there. And the new drugs, we don't have a good idea of what they're going to do. It's a little bit, and Jack, tell me if I'm speaking out of turn, but I think it's a little bit with some of these drugs trial and error. And so we do offer those to patients sometimes when, I don't know. I'll leave that to Jack to answer.
And there you go, Jack.
There you go, Jack.
Yeah, pick that right up, Jack.
Take it up.
It is the Wild West. I think for most new drugs that come into the system, we have a fairly good idea what to expect. Although it is clear, particularly with the pressure to get new drugs into the system that are active against treating cancers, that sometimes things come in maybe a little bit too quickly. There's kind of conflicting. We want to take our time to make sure we get this right, but then there's tremendous pressures to get new drugs that are active into the system. So anytime we start treatments with a new therapy, we always have to be very alert to something might be happening that really wasn't reported in the initial trials that got the drug approved, because maybe the drug was not tested in the broad array of patients that it should have been tested in before the approval came, because it looked like it was such a good drug. I think one of the best examples of this are the immunotherapies. I think most people know about the immunotherapies, which have really just come out in the last couple of years. All of a sudden, I'm a rheumatologist. I mean, I'm taking care of people who have all sorts of problems that I didn't think I'd be taking care of just because of the side effects of the drug. You can get all sorts of autoimmune problems, and you have to be alert to those things. So again, we learn these things as we go, but I think that's part of my job as an oncologist, is to be able to integrate these new things with unanticipated side effects, and to take care of my patient adequately, despite this maybe being a therapy is relatively new to the entire system, not just myself. So,
Well, you kind of got diverted off the question, so I'd like to bring you back. Thanks for that, Catherine.
I was just defending myself.
In terms of that,
No, I wasn't.
cost savings, reducing the cost of healthcare, because when you and I talked initially, you talked about some initiatives that Bozeman Health is, that you're leading.
We're trying to lead. Someone asked me what I did at the center. I told them I herd cats. I think it's important to know that there's a lot of what I cannot do to control costs. Drug costs are incredible. How many people here know about the CAR T cells? Okay, so CAR T cells are a biological therapy. They're modifying your T cells and putting them back into you, but in the meantime instructing them so they know how to find your cancer cells. This is just approved. It's kind of a big deal. It was just approved in the last couple of months by the FDA. The price tag on that is $600,000. Okay? I have no control over those costs. The new drugs that come into the system that are highly active in treating cancers, no control over those things. The PARP inhibitors, which have been approved for use in ovarian cancer and probably will soon be approved in breast cancer and prostate cancer. I just saw the price tag on one of the new ones of $18,000 a month. Again, we don't set those prices. But I think what we can try to do is begin to look at the pieces of the healthcare cost puzzle. And again, I think everyone knows cancer care is incredibly complex, requires multiple people involved. And we can begin to look at how to administer that better to avoid excessive use of not necessarily therapies, but approaches that are really very, very expensive. I think one of the things I learned since I've been here in Montana, when I came here, I think it was estimated that about 60% of the money flow through a cancer center was simply the cost of the drugs that were being administered to the patients. And that was 13 or 14 years ago. It's probably different now, but it's about what it was then. So I always viewed the drug cost to be the most expensive. But I'm the current president of the Montana State Oncology Society. I go to a bunch of national meetings, hear policy. And I was surprised a couple of years ago to learn that really in the lifetime of a cancer patient, the most expensive, the biggest expenses actually have to do with the hospitalizations and the emergency room visits. So if we can do a better job of taking care of our patients and reducing their hospital admissions and reducing their emergency room visits, these are ways that we can begin to impact on the overall cost of healthcare by kind of altering the culture in terms of how we administer care. So I think.
Great, thank you. Noelle.
That's a perfect segue to what I have to say about complementary care is, the impact that we can have in reducing overall health care in making sure that we're taking care of you before you have to get to the hospitalization or the emergency room care. There's so much we can do to keep you hydrated, to keep you well fed, to support your mental emotional state, et cetera, that there's numerous studies to show that preventative care can save money for the consumer, for the insurance companies, et cetera. Now that's also a very, very complicated subject, but I see on a weekly basis, I see patients that, I see the gamut. I mean, I see patients, I'm there with them at the time of diagnosis, all the way through. I see patients in thrivership. So part of my job is, the biggest part of my job is being an advocate for the patient and helping them navigate, like Catherine said, what matters to them, and when it comes to their health care, empower them with well-educated choices around evidence-based medicine. So, cancer patients have more options today than ever. And I saw a patient this week. She's been through a route where she spent almost $100,000 out of her pocket going around the country trying all different kinds of alternative therapies, only to be circled back, and now we're talking about chemo again. And I can't even imagine what it would be like to be already $100,000 in debt before you even enter the conventional medical system. So I feel that we have to save costs for the consumers that are again, pouring money into places. And again, I'm not saying I'm not judging those choices. There are lots of, I could tell you just as many stories about very positive journeys that patients have taken and where they've put their dollars. But ultimately, it's very difficult for me to be in my position and want to see patients. You know, I have patients that can afford to see me, but they almost have too many choices. And then I have patients that can't afford to see me at all because insurance doesn't cover what I do. Medicare and Medicaid does not cover naturopathic medicine at all. And then other insurance companies in a very limited way. Now, luckily, that's changed in a positive direction since I've been in the practice of medicine, but we have a long way to go in order to get coverage for anything outside of the conventional and to help people navigate where they're putting their dollars for cancer care.
Yeah, I want to speak to Jack's point about the hospitalizations and ER visits. I think if you really have a strong palliative care program that can go out to the home, people always get surprised to hear that I do home visits. Some of those visits really can be eliminated. The other thing is also with palliative care, if we can control symptoms better, then I think we do a better job of dealing with hospitalizations and ER visits. So really having a strong palliative care program can help with all of that.
One other comment, I think this does speak a bit to care as well, to cost as well as quality. We all know that taking care of sick patients who come into the system incredibly sick, is much more costly than taking care of patients who are in good shape when they come in. And on the way up in the car, Noelle and I had a short discussion, relatively long discussion. One of the things she asked me was, do I think that we really are doing excellent care in this country? We certainly hear statistics that say, compared to other developed countries, we're not doing very well. And I think you have to look to see, I have no question that the care that is administered in this country, if you have access to it, is the best in the world. But access is a real problem. And the reason we do so poorly in things like neonatal deaths, infant deaths, is just because of inadequate access to care. And I think if we can focus on issues of care delivery and how do we do a better job of getting care out to people. And again, I think that's one of the challenges in Montana. It's a very large state that's understaffed with healthcare providers. How do we do a better job of that? And I think that can also begin to look at bringing down costs because you're not taking care of patients who are so incredibly sick when they come into the systems.
I just, in addition to that, I was struck by the previous panel, and what struck me most about it was not only the emotional cost of the whole illness, but what fighters you all were. And not everybody comes to this diagnosis of cancer with that sense of fight. And you shouldn't have to fight that hard to get the care that you need. So.
Wow, thank you. So let's shift gears for a minute and talk about the legislature. And I'll start with you, Jack. I'm trying to think when this was. In 2011, you championed House Bill 615. Representative Williams carried that bill that required the insurance commissioner to study equitable treatment by insurers for cancer patients seeking to participate in clinical trials. So that bill passed, got signed by the governor. I'd just like to have your thoughts on whether you feel like what you were looking for has happened, whether the outcome has gone the direction you'd like to see it go.
I think in general it's been a very positive step. Again, I've mentioned at the beginning what I focused on when I came here, which is providing access to high quality cancer care for people in the state. High quality cancer care includes access to clinical trials. And when I came here, I was shocked to find out that I couldn't put patients on clinical trials because the insurers would not let that happen. I wouldn't say that putting patients on clinical trials is a cost-saving maneuver, but it adds no additional cost to the system while it improves quality. So in that sense, it improves value because you get better care for the same dollar. And so I think in 2011, as Bill said, I forgot because I've a lot of water under the bridge since then. We embarked on trying to get this bill passed so that patients could not be denied enrollment on clinical trials. It was actually a kind of an eye-opening experience and was probably one of the first things that got me to thinking a little bit more about health policy. But yeah, there were interactions that with politicians that were really quite favorable, realizing that these people aren't always our enemies. There are interactions with insurers who I generally don't like to interact with because most of the time we're fighting with them about payment. But you kind of begin, you do begin to get their side of the story. And delivery of cancer care, as I said, is very complex. The payment for cancer care is very complex. It's not easy for anybody who's involved in that task. And I think it was a very good experience for all of us who were involved to be involved in an interactive process. And when we brought that bill, the bill was a 2 legislative session piece. They set us to work and talk to each other between the 2 sessions, and that was when I got to meet many of the people who represent the insurers throughout the state. And I think highlighting how important and beneficial that was, when that bill passed in the 2nd session, it passed unanimously. I think there was actually 1 vote that was against it. I'm not quite sure why. It was from Bozeman.
Really?
I think so, yeah.
Shocking.
Anyway, but the insurers, who were the initial people pushing back against the bill, also stood up and spoke in support of the bill. So it really spoke to how working together you can really make progress. And I'd like to say one other thing that I learned in that, which I think is, again, a unique thing about Montana, and I encourage you all to stay engaged. This is a small state. Almost everybody knows somebody who's in the legislature. And those people want to hear from you, and they are going to be responsive to you. It's not, this is not New York. And this is a small town, essentially. And there are opportunities to have political impact if you want to take the time to do so.
So, Catherine, you talked about your bill, which passed last session, House Bill 285. Wendy McCamey carried that bill, an act establishing a palliative care access initiative, creating the State Palliative Care and Quality of Life Interdisciplinary Advisory Council, and requiring a palliative care consumer and professional information and education program. So, realizing that this hasn't been in effect that long.
Correct.
How do you feel about where it's at, and are you getting where you'd like to go with this?
So, well, we just started. We had our first meeting September? We had our first meeting in September, but we've had a coalition that has been working together for, over 10 years to look at issues around palliative care in the state of Montana, including, we started out looking at advanced care planning and the PULSE document. That was sort of the first, how we got started. What the plan is for this council is to really, first of all, find out what is going on in terms of palliative care across the state. We know through that any certified cancer center needs to have some palliative care access within their cancer center. So what really is going on in the cancer centers? What's going on outside of the cancer centers? For example, in Bozeman, we've had a palliative care inpatient service that sees over 600 patients a year, which for the size of Bozeman is a lot. And provides amazing care within the hospital. What's going on in the outpatient side? What's going on in the cancer side? What also are the standards that, can we come up with any standards for these programs? The saying is, you've seen one palliative care program, you've seen one palliative care program. But the other thing that we really want to do is there's a lot of information out there, and to really put it into one website so people know where to look for appropriate information about palliative care, where to get it, what it is, what benefit you can have from it, what are the standards around advanced care planning and talking about your wishes and your desires around health care, those kind of things. And we plan after the next year probably to have that on a website for the state of Montana so everybody can have good access to it and know where to get palliative care.
Great. And I didn't prep you for this question, Noel, so I apologize, but there's at least one legislator in the room, so is there anything that could be done legislatively that would help you in your endeavors if you were queen for a day and had a wish?
Yeah, not on the spot at all. That's a great question, Bill. And, I think first and foremost, we just have to get, for me, naturopathic care, but other complementary care, covered more and more by insurance, and really that has to start with Medicare and Medicaid. I mean, it has to start there. So we have to work on that level, and we have associations that are working very hard and have lobbyists, et cetera. But it's got to happen. We've got to get it covered. Now, that's not going to take care of everybody, but it would be a very good start. So I would say, efforts just have to be made to get more complementary care covered by Medicare and Medicaid.
Well, you have some folks from representing.
I couldn't support that more. It's key.
Thanks.
All right, great. Well, good luck with that. We'll see, we'll see what happens.
It's just the beginning.
So speaking of that sort of thing, the landscape in terms of reimbursement has certainly changed with Medicare, Medicaid, escalating co-pays, escalating premiums, escalating deductibles. So I'd just like to, I know where you're at on it, and I may go down a different road with you, Noel, but Catherine, maybe start with you. What do you see in terms of how this affects access and how it affects people that have cancer and how they're having to deal with these sorts of issues?
Well, I think it's huge, actually. It's very frustrating as a provider to try to really provide the kind of care that I want to for patients. Part of it is not being able to get them good integrative care. So I can get patients to physical therapy for some rehab, but I can't get them to acupuncture. I can't get them to massage. I can't get them to some of the other things that I know would really help them because I don't have the money for it. The other issue, and don't throw rocks at me, please, but there's been some real difficulty for my patients in getting appropriate opioid therapy. And the insurance companies have stepped up in a way that actually has really, really limited access to appropriate, and I stress that, appropriate pain management for patients with cancer or patients surviving with pain that is residual from cancer treatment, of which I have a number of those. It's really been extremely difficult in terms of getting them the right kind of care, and even something like methadone, just so you know, is a very good pain management tool that I have, and is very cheap, and yet some insurance companies are refusing to pay for it even though it's cheap. So there's a lot of restrictions that I'm facing in terms of symptom management and trying to take care of patients that has recently come to the forefront. It's gotten pretty difficult.
Jack?
Cost of care?
Well, just access as relates to reimbursements and insurance, the changing landscape of how insurance is handled now.
It creates, as with many things in cancer care, even payment is highly complex. Again, Noel and I had a very nice conversation in the 3-hour ride up here. We talked about, I think we employ 5 people full-time in our cancer center who really do nothing but wrangle with insurance companies to make sure things are paid for that should be paid for, and also working with things called copay foundations to ensure that patients who, even though they have insurance, can get their drugs because the cost of the copay is so high they otherwise couldn't afford it. So if you don't think those kinds of things don't add to the cost of delivery of care, it's silly. I think, when I hear all the conversations, and this is just going to be a more global statement, I think, about where I stand, the cost of health care and cancer is one of the drivers, that's for sure, because it's very expensive to do cancer care. That's going to go up regardless, as long as the technology goes up. I had a conversation with my sister a couple months ago who said, why is it so much more expensive now than it was in the 1950s? I said, well, we had penicillin and polio shots. There's a few more things we can do now. And I gave you the example of a new therapy, which is great. $600,000 for that therapy. So the costs are going to go up as we get better and better. When you can't do much, it's not very expensive. When you can do a lot, the costs start rising. But I think the biggest argument that's going on right now is really who's going to pay. That's the political conversation right now. Nobody really phrases it in that terms. But is it the government? Is it you? Who's going to? Is it charity care? If it's charity care, it's still you. So it's not being phrased that way, but that's really the conversation that's going on. The cost of care and what we do about the rising cost of care, many people are extremely concerned about that too. And I think that needs to have another separate conversation because those are, I think, distinct issues.
So, Noel, you don't get reimbursed by anyone for the services that you provide. So, how does that impact access and your patients?
Oh, it greatly impacts access. I mean, without a doubt. A first office visit with most naturopaths, is $250. Now, you're with the doctor for about an hour 15, an hour and a half. And then we've got, follow-up visits. And ideally, you're seeing, anywhere from, 15 to 19 times in a year. I mean, it could be even more than that, depending on what you're doing. Oftentimes, I'm not the only one I want you to see. I want you to see your acupuncturist. I want you to see your massage therapist. I want you to see a whole team. The first visit, really, for me with a cancer patient is building their team. So to your point, Bill, no, I'm not reimbursed, so I'm also a small business person with overhead, student loans. I have student loans on the scale of most any primary care provider. And so as much as I want to give away my services, I have to strike a balance. And luckily, I have partners that I work with, and we do our best. We're constantly looking at the landscape of insurance, any way we can possibly get in the game to help our patients. We look at that almost monthly. We sit and look at it. What can we do? What can we do? Right now, with Spring Integrative, we offer what we call a community clinic week 4 times a year, and it's not enough. But 4 times a year for a whole week, we see patients at a drastically reduced cost. All the money goes to another nonprofit in our community. Our patients love it. I've got pages and pages of cancer patients on wait lists to get in. So sometimes, I'm seeing a cancer patient 4 times a year because that's when they can afford to be there, understandably. So, we also do our best with sliding scale fees too. That's another way, we try to balance the idea of being able to manage a business and overhead and still, provide for our community. But it's, it's very, very rare that I have a patient that can come and just, again, spend $100,000, and that patient, that $100,000 was not with me. She's now with me because she spent that $100,000 out of her pocket, and she's kind of still at square one, and she's saying, okay, now what do I do? So it's a very tricky landscape to try to provide the care that we want to provide and still be a viable business so that we can provide care. Definitely.
I would say one other thing about again access to care and cost of care. To strike what Noel had to say, how we handle payment for care is so fractured in this country. We have many patients who come to our cancer center. It is our policy, we treat everyone. The hospital works for them on our social workers work with them to try to see if they're eligible for Medicare or eligible for Medicaid, and try to get access to care. Some patients, you just work out payment schemes and write off a bunch. But again, it really, at that point, the hospital now, as part of the fundraising that the hospital does, is money goes to defraying the cost of patients that couldn't provide their own care. And so again, it's part of this decision process of who pays for health care in this country. And again, I think it's a conversation that has to be had in a much more out-front way, rather than just say, well, we're not going to pay, and so you guys figure it out.
So go ahead.
Just
Jen.
one other thing, which is that, as a provider, and I feel terrible about this, I have no idea what I'm charging. I mean, you probably have a better sense, Jack, because you know at least the cost of the meds. But when I see a patient, I have a vague idea of what I'm charging, but I don't really know. And what other places like that? What other services like that where, as somebody giving a service, we don't really know what our cost is? So it's hard for us to actually, for me to look at, say, how can I control this cost, except that I know that I can't, insurance doesn't pay for Noel,
Just one other comment about that. I came from an academic medical background, and I will tell you that, again, our academic medical systems are the absolute best in the country in terms of figuring out how to improve treatment of diseases. There's almost no attention paid to how you deliver health care, and they're starting to pay attention now to the cost issues and how do we fit into that thing. So I think in terms of any rational thought process about this, most of what we focus on in academic medicine is how do I treat breast cancer? How do I do a better job? And you do that, and you want to do that the best job you can for the patient without having one thought in terms of letting the cost of that enter your mind. And that's not a viable option anymore.
Okay.
Well, I was just going to say one more thing in terms of cost. I had a patient recently who's on hospice. I do a lot of hospice work, and she got a letter from our radiology department saying it was time for her yearly mammogram. Now, I understand that on the one hand. On the other hand, I'm like, this makes no sense for this person to get this mammogram, but we do these routine things that slowly add to the cost of what we're doing without paying attention to really the whole picture.
So shifting gears here, and I didn't give any of you a heads up on this question because it's really of interest to me. So we heard the previous panel talk about caregivers and patients. I want to know about you. you guys deal with this every day, patient after patient after patient. How do you manage your mental health as a provider in this arena? Go ahead.
Okay. Well, I live in Bozeman, and I'm sort of half joking, but we were extremely lucky to find a place that is at the end of the road. I can go to my house, I can go to the backyard, and there's nothing between me and Yellowstone, so I can hang out there. You know, people keep saying, God, you do such a hard job, and I get such incredible, when things go well, I get such incredible gratitude from my patients and from their caregivers, and that makes it really special. I also have 2 wonderful dogs, and I don't mean to put them in front of my husband and my kids, but you know, I come home, they're always happy to see me. And I have a great family, and then I exercise a lot. I try to do that, and then there's the martinis. So,
Noelle.
Let's see. So I would, I'd be in big trouble if I said I didn't do self-care, wouldn't I? As a naturopathic doctor. But yet I would say, I would second what Catherine had to say. And this isn't to sound like a martyr, but I couldn't do what I do if I didn't have the amazing patients that I work with. And you know what? They do a lot of my job for me, and meaning that they stay informed, they bring me information, they push me to be better and better and better, to learn more, to participate in events like this, to figure out what I am passionate about besides the actual patient care. So I'm really fueled by what I do, and that makes me an incredibly blessed person, I think. Outside of that, I do have to practice what I preach. So I've got to sleep, I've got to be physically active, I've got to eat as well as I possibly can, including birthday cake on my birthday, and I've got to make sure I eliminate, whether it's mentally, emotionally, physically, whatever it is. So thank goodness for good counselors and social workers, et cetera, colleagues. And you know, then I tell my patients, there's this 5th category of the foundations, right? I've just mentioned 4, and there's this 5th. And it's sort of this unknown. And right now, I just call it self-care, because it could be anything for any of us. It could be walking your dogs for one person. It could be, you know, Buddhism for another person. It could be the birthday cake on your birthday. But I almost have the most fun with that piece with my patients, because that's where we figure out what matters most to them. And I have to tell you, it's what makes the difference in their care. The patients that I see absolutely thriving to this day have managed to marry, again, the conventional system. They've also brought together their foundations, and that's not easy. Like Amy mentioned, this can be a total life changer for a lot of us. And they have figured out a piece or two. They've created for themselves a toolbox that they come away with that they can go to for their self-care. And you know, that to me is the ultimate outcome for me and for my patients.
Well, this is a hard question because nobody's ever used mental health and me in the same sentence. And anybody who knows me would probably say chocolate. But in reality, to mirror what I think has been said here earlier, I have the best job in the world. And so I can't get down. It's fantastic what I do.
Thank you. So this is the final one for you, and maybe we'll have time for some questions. So on a daily basis, you're faced with people coming to you wanting hope, whether it's hope to survive, hope to be cured, hope for another day, another month, another year. What makes you hopeful in your arena as you look forward that you think kind of guides you and is heading you in a positive direction going forward, doing what you do? Let's let Jack start.
Yeah, Jack, you start, okay?
Catherine, how can we keep you from talking? I don't
I know,
believe
it's
you're
really
ceding
tough.
the-
I know,
you're
I
ceding
know.
the- You know, it's hard. I mean, I've been doing this for obviously a few years. The advances are just dramatic. And I think we're ultimately, I mean, we've learned so much about cancer in the time that I've been involved in treatment. Again, I think that's creating problems because now we've created something that's almost too expensive to do. But our understanding of how to handle this disease has advanced infinitely in the period of time I've been involved, and how you can not be hopeful about further advances in that when you've witnessed that over the last over your lifetime in the area. So I think that's the biggest thing I'm hopeful about. Again, I think, as I said, that's created problems. There's ethical problems and there's financial problems that are all spinning out of this. But since our goal is to treat people and we're doing it so much better now than what we did, it's hard not to be continually hopeful.
I would agree that I think the advances that we see, not only for me as a provider, but just for my patients are just more and more well-educated and prepared to make choices. That gives me a lot of hope. Now, yes, there's a lot of catch-up to do in terms of finances and resource availability and education, but I'm hopeful because when I was, when I even looked at going to naturopathic medical school, I wasn't sure I could make a living. And I can. I wasn't sure I'd be able to reach enough people, and I'm doing the very best I can. And I'm really surprised at the outpouring of people that want the care. And also, I'm really hopeful because I do live in a community where I feel very supported. And I'm not sure it's not, just one of the best places in the country for me to be practicing, because I have so many colleagues, not only just within my small little practice, but in our community. And I don't, the idea of integrative care is more supported now than it's ever been. So as long as we're holding groups like this, as long as I'm sitting with these people and with all of you, how could I not have hope that this is only going to get better and better in terms of the care that we can provide for our cancer patients?
So I have a couple of reasons why I'm hopeful. One is that I teach a bunch of medical students, and my daughter is a medical student, and I see some of what they're learning and how it was different than what I learned. And that makes me quite hopeful about what's coming around. But the other thing that makes me hopeful is really the growth of palliative care. And I say that because the key thing with palliative care is communication. And more that is being stressed as a way of helping people cope with serious illness. Where there's just more and more emphasis on sort of what we call shared decision making, and really having patients come in and talking about what matters to them, as I started out, as well as what is the matter with them. And that really gives me a lot of hope that is really being brought to the forefront in more and more places.
Excellent, thank you. We do have a couple of minutes. If there's any questions, anybody have anything they'd like to ask of these panelists? I have one back there.
Wait, Mike, it's on air, so let's.
Well, thank you. What a great panel. So a couple of times you mentioned the palliative care council. And so what I'm wondering is, can you tell us more about where you meet, when you meet? Is it open to the public? How do people find out about all that information and what your agenda is for that particular meeting? Is it open to the public?
Oh, absolutely.
Can anyone
We have, because we had this initiative that started years ago, anybody can come to it. The panel, the advisory council itself has been appointed by the Department of Public Health and Human Services. So I think there are 4 doctors. There's spiritual care, there's social work, there's, help me, Kristen, there is a survivor, there is, it's very interdisciplinary. As I said, we've met once. We're going to meet again in April in Helena. And
Where?
Where in Helena? Where are we meeting in Helena? Have we decided? Have we figured it out?
So definitely give us your email if you want to be on our listserv. We have the Montana Palliative Care Initiative listserv, and we announce all of that information on that listserv.
Right. I think the meeting is April 17th on Wednesday, and we don't know where yet. It may be at St. Pete's. It may be, where did we meet last time? Oh, we met at the
Hospital Association.
Hospital Association. Yep. So it is definitely open to the public, and we welcome that. And the agenda is, just to address that for a second, is one, surveying the palliative care services available in Montana, creating a website so that everybody can have access to that, promoting advanced care planning within the state, and one of our big agenda items, actually most recently, is there's a big palliative care conference that's being scheduled for 2019 in Billings, and we're going to be participating in that. So.
Anything? There's one right here.
Oh, wait.
Microphone.
Sorry, that's okay. I'm curious about how, in terms of learning from other communities that might be doing something slightly different. I'm curious what kind of exchanges, like knowledge exchanges, are happening where there's maybe more comprehensive or integrative care, and then maybe working well with different payers and kind of more of a collaborative approach. And I'm curious if there's been any communities that have been cited that are successfully doing this that we can learn from and kind of borrow some models.
I think that's a great question, Amy. We have a naturopath on staff in Billings. We have 2 on staff in Kalispell. There are naturopaths on staff with a lot of hospitals in our country. There are a lot of MDs starting their own kind of integrative clinics, like the Center for New Medicine in Irvine, California. There's several in Arizona, Colorado, all over. Oregon, exactly. So to your point, yes, there are definitely communities, and I'm watching them like a hawk and trying to learn as much as I can. I will say, ideally, integrative medicine, yes, it's all under one roof. All covered by Medicare, Medicaid, et cetera. There's a system there, but it can be done in a lot of different ways. I feel like since 2009, I feel like it's been successful in our community to work with our cancer support community and with the Cancer Center. I get into those spaces as much as I possibly can. I've even been allowed to be in and work with patients while they're having chemo infusions, and nobody's kicked me out. So, it's possible, and yes, there are communities. Does that answer your question, Amy? Okay.
Okay, we got done with 1 minute to spare, so Kristen, I'm out of trouble with you.
Good job.
Thank you to the panelists.
Understanding and Mitigating the Economic Costs of Cancer. Bryce Ward, PhD, Associate Director at the Bureau of Business and Economic Research, Director of the Bureau's Healthcare Research Program. Well, I know a few things about him that some may not. So instead of just listening to his academic credentials, which are massive and wonderful, I knew that would happen. He is also a caveman. He's a fourth-generation graduate, thank you, of Grants Pass, Oregon High School. So, we have a caveman with us. His former students went off to found Facebook, Blue Apron, and Give Directly. Welcome, please, Bryce Ward.
All right, is this thing on? Did I turn it on? Hello? All right, I'm going to move it up a little closer then. All right. I can tell you the energy in here is palpable. You know, I'm sure when you picked up the brochure, the schedule, you're like, oh my gosh, at lunchtime, not only do I get to hear talk about cancer all day, but then I get to hear an economist. No, in fact, I'm pretty sure that my title alone depressed attendance. Understanding and Mitigating the Economic Costs of Cancer. You know, yes, it's a really, really boring title. But I started to kind of gin up like the creative juices. I was going to come up with something more interesting. But then this like scene from Brighton Beach Memoirs popped into my head. I don't know if you've seen Brighton Beach Memoirs, but you know, it's a Neil Simon play / movie. And there's a scene in it where Eugene, he's the main character, he's like this 14-year-old guy, he comes out and he sees this funeral procession, he has this conversation, he has a little monologue where he's like, why is it old people always whisper what somebody dies from? Like my Uncle Dave, Aunt Blanche's husband, he had cancer, right? People from the old country think it's bad luck to say the disease out loud. Like if God hears you, he'll give it to you, right? And that was going through my head as I was coming up with this title going, I don't want to get cute, right? I don't want to take the risk of ending up tempting fate. So we have a very boring Understanding and Mitigating the Economic Cost of Cancer title. Hopefully the talk will be more interesting than the title. So just to get the lay of the land, basic facts. There's about 56,400 Montanans have cancer. It's 5.6% of the population. Our incidence and mortality rates are roughly on par with the nation. 441 people per 100,000 will get cancer. 157.8 per 100,000 will die. And then you kind of add this all up, and you know, cancer is an expensive thing to treat. And so Montanans spend roughly $460 million a year treating cancer. Right? Just to put that in perspective, that's 1% of the output of Montana's economy. That's basically twice as much as the state spends on higher education. And that's only about half of the actual total costs of cancer. You know, there's the half that we're treating cancer, but then there's these other costs which we're going to talk about that spill over into the rest of people's lives. So cancer is a big, expensive deal, right? 1% of our economy. That's non-trivial, right? I can put it in 1%. Montana isn't even 1% of the U.S., right? The whole state of Montana, right? We're 0.3% of the U.S. population, or the 0.3% of the U.S. economy. So 1%, that's big, you know, when you talk about something the size of an economy. So that $460 million and the other ancillary costs, so roughly $1 billion, if you think about the total cost, obviously this creates problems for individuals. So much so that some of the oncologists who deal with treating these people started to end up doing research, and they actually coined a term for the cost of treating cancer, or the byproducts of the cost of treating cancer. They called it financial toxicity. Of course, they're oncologists, so they think in these terms of toxicity, in terms of, oh, we treat people and it's toxic, so we call it toxicity. So when we treat people and it imposes a financial burden, we're going to call it financial toxicity, right? Which is, of course, harmful personal financial burden faced by patients receiving any cancer treatment. So, okay, well, where does this toxicity come from, right? Well, it comes from the fact that it's a burden for people to have cancer, right? So a bunch of studies have been done. They use different metrics, so the numbers here are kind of all over the place. But somewhere between 15 and 75% of cancer patients will tell you that they faced an economic burden as a result of their disease. Right? Kind of the consensus estimate says it's probably about a third, somewhere 30 to 40% of people will tell you that they suffered some sort of severe financial hardship as a result of cancer. Okay, so where does that come from? What's the source of that? Well, the first thing, of course, is that cancer is expensive. And so recently, the Milliman Institute did a big study where they took and they looked at the cost of cancer from the time of the initial diagnosis, out for 4 years. Right? So if you get lung cancer over the first 4 years, it's going to cost you about $300,000, or the cost of the system about $300,000. It's the yellow solid line. If you look at the dotted line, that's out-of-pocket costs, and it's measured on the right-hand axis. Right? So a lung cancer patient over the first 4 years is going to spend on average, about $10,000 out of pocket. For people with breast or colon cancer, those are the other, the two bluer lines. It's more like, maybe $7,000, $8,000. Of course, that's just average. There's enormous variation around this. If you look, into the other studies that look at out-of-pocket costs, it's not uncommon to see $4,000 or $5,000 per year averages, and you'll always see somebody in the kind of $100,000 range. Right? There is somebody who's spending $100,000 out of pocket on their cancer treatment. Right? You'll see them; they're there. So the distribution is wide, but here's your average. So okay, that's the level. How should I feel about that? Right? So in order to actually understand a financial burden of something, it's one thing just to know how much it costs, but you also need to know what's my capacity to pay those costs. Right? So i.e., how much income or asset do I have? Right? So when we look at that, we find out that lots of people are underinsured. Right? So 13% of non-elderly cancer patients spend at least 20% of their income on out-of-pocket expenses, and 50% of Medicare beneficiaries spend at least 10% of their income on out-of-pocket cancer treatment. Right? So usually we use this 10% threshold as the underinsured line. So this means that many people are underinsured. Another way to look at it, of course, is to say, well, not look at income, but just what do you have that you could tap into? What's your assets, right? So the Kaiser Family Foundation recently did this. They took this thing called the Survey of Consumer Finances, and they asked the question, okay, given what people tell us in this survey about their level of assets, particularly their relatively liquid financial assets, so things in bank accounts or stocks, things that you can sell pretty easily. And then, okay, let's posit that this household suffers either a mid or a high level out-of-pocket shock, where they define those as mid is $3,000 to $6,000 and high is $6,000 to $12,000. And just look at the bars over on the right. If you're over 400% of the poverty line, okay, great. 75% of those families can handle a mid-level out-of-pocket shock. But if you're at the 100 to 250%, only 18% can have assets on hand to handle it, right? And if you're somewhere in the middle, the 250 to 400, it's 43% can handle a mid-level. If you get a high-level shock, of course, those percentages go down. So here we can see why we have a burden from large, unexpected out-of-pocket costs, even in the few $1,000s range, right? Is that most people, overall, if you go over the ones all the way to the left, a majority of households do not have assets on hand to cover this, right? A different survey that the Fed does, the Federal Reserve does, they actually just ask people in words to describe their greatest financial fear, right? So you talk to affluent people, their fears are college savings and retirement savings. Right? You go to really poor people, they're screwed. They're worried about everything. Right? But your middle income people, the thing that comes up far and away the most is healthcare. Right? Because they're the least, this is the shock that they know is out there, but they're the least prepared to deal with. So this is a burden. Obviously, out-of-pocket costs are an important source of this financial toxicity, but it's not it. Right? We've already heard from people today that it's not just paying for medical care. Right? There's other costs that come when you're given a cancer diagnosis. And we refer to these as indirect costs, and that means things like travel, but also means kind of employment effects, right? Like, so here again, we're going to look at things by some common cancers. On the left, we got people who are, I'm sticking in my job because I'm afraid to lose my insurance. Right? So that's 20 to 30% depending on the cancer. In the middle, we got people where I actually changed my employment or my career. And again, in those three, we talked about earlier, breast, colorectal, and lung, so 70% of people who get that diagnosis make some change to their career. And 50% of them say that their productivity was adversely affected, which is probably an underestimate because I'm guessing it's probably 100. But These are big. These are big, right? So then when the wonky nerds like me sit there and say, okay, well, how do we try and measure this all together, right? Let's put the out-of-pocket costs, the direct costs, with the indirect costs, right? So let's try and figure out what these effects are. And so we use these surveys, we kind of do this. And recent evidence suggests that for people in the kind of that first year or so after diagnosis, the annual cost of both out-of-pocket costs plus these lost wages and productivity and other out-of-pocket costs is about $16,000, right? But you're not done if you make it through the first year, right? Cancer sticks around. You keep paying the cancer tax. And if you were just previously diagnosed, but as you move out, you basically are averaging about $4,400, $4,500 per year in either lost wages or higher than non-cancer patient out-of-pocket costs. Those last for a long time. A separate study than this one, but just focused on people who are diagnosed with childhood cancer, finds essentially the same long-term effects: $3,000 to $5,000 in either higher out-of-pocket costs from follow-on healthcare things or lower output and productivity. Right? So then we take this combined, and it's probably not terribly surprising that if you receive a cancer diagnosis, you're 2.65 times more likely to declare bankruptcy. Right? So the financial burden of cancer is large, right? It's fair to say that cancer sucks. Although when I typed that, I actually got this nervousness in my stomach, right? Because I can remember being an 11-year-old and being like, "Mom, that sucks," and her getting all mad at me because "sucks" was a swear word. But so I actually went and found a quote which allowed me to put it up here. We don't travel, we don't do anything now because it's a $100,000 illness and it sucks. What are you going to do? Caught between a rock and a hard spot. 67-year-old insured woman with metastatic breast cancer, right? The individual cost of cancer is substantial, but it's not just easily measured in dollars, right? There's additional costs, additional things that we have to kind of think about, right? In fact, if we look at cancer, but in particular if we look at the intersection of cancer and financial distress, right? People who report financial distress and report cancer are even less likely to report that they have good well-being. They are more likely to report poor health-related quality of life. They're also more likely to report that they modified their treatment, I guess is the way I'll put it, right? So that means they, skimped on a dose, didn't do something that they otherwise would have. So you put all those things together, and of course, then extreme financial distress has actually been now correlated with greater risks of mortality. Again, it's a small study, so we don't put too much of it. But cancer patients who declare bankruptcy are 79% more likely, face 79% higher mortality risk. Right? So the individual burden of cancer, the financial costs, the spillover indirect costs, the mental health costs are large. And of course, none of this really deals with caregivers. Right? So there's a little bit of that in some of these annual costs, but obviously this spills out into your caregiver. It spills out into your employer. 50% of people who actually are reporting declines in productivity, that's an effect on your employer. Right? So it's not just the individual who's unfortunate enough to get a cancer diagnosis who suffers. Their circle, the wider economy also suffer. Right? These are big. Now we're feeling really charged up and happy. So I thought I would have our good news break. So here's your one moment of sunshine in this dreary talk. So this actually popped up in my Twitter feed just this week. And conveniently enough, I was born right in the middle of the period at the right-hand dots. And this kind of comes out towards almost recent. And this is the change in 5-year survival rates for cancer. Right? So when I was born, across all cancers, 50% of patients, 50-50 if you made it 5 years, right? Now we've made that up to 2 and 3, make it 5 years, right? So good job, right? So this is good. This is good news. And because I'm a nerd, it's not enough for me just to say, hey, look, a 16 percentage point increase in the survival rate for cancer. I got to put a dollar value on it. I'm an economist. Fortunately, we have a paper, very famous paper written by 2 University of Chicago economists, written over a decade ago, so these numbers are a little out of date, that was looking at the value of greater life expectancy over 1970 to 2000. Right? They basically said, look, The gains in life expectancy from 1970 to 2000 added about $3.2 trillion a year in value, right? So obviously you can take that, looking ahead, right, get to the bottom, right? A permanent 1% reduction in mortality from cancer has a present value to current and future generations of Americans of nearly $500 billion. Right, so if we've improved 16 percentage points times 500 billion, right? That's $8 trillion of improved value. Maybe it doesn't quite exact translate because of 5 years is not maybe exactly the same. But well, if we had a cure, if one is actually feasible, a cure for cancer is worth $50 trillion. Right? That's the value, right? So it's expensive, sure. We're going to talk about expense. We've been talking about expense, but it's really valuable to be able to live longer, right? Shocking, I know. So how do we figure out what this value is? We basically do an exercise, and we try and find actual experiments where people make this trade-off. But I'll give you the hypothetical version, which is to say, look, say in 1900, the average life expectancy at birth was like 50 years. Today it's 80. Right? So I want you to imagine that God comes to you in utero and says, I'd like to play Let's Make a Deal with you, right? Behind door number 1 is the life expectancy from 1950, or 1900, sorry, 50 years, plus a giant suitcase of cash, right? Behind door number 2 is an average life expectancy of today, 80 years, right? The question that the economist has to answer to figure out the answer to this question is how much money does God need to put into the suitcase to make people indifferent between the 50-year lifespan and the 80-year lifespan, right? Now, I'll let you think on that. So imagine I'm here and you're dressed up in a weird costume and I'm Monty Hall. And you got to say, okay, well, what do you got to bet on to be in that suitcase? And well, the answer is roughly several $1 million, a couple $1 million. So just by being born today, you are endowed with several $1 million of life expectancy, right? So when we improve cancer, maybe I'm not adding all 30 years to your life, although some child cancers probably have. But even adding 5 years is worth a lot. Right? So hence curing cancer, our good news break. We've got a lot of value even though it's expensive. Okay, so, well, it is expensive. So how do we do better? Right? How do we lower this burden of the cost of care, right? So option 1 is we've got to be better prepared for the fact that this kind of shock can happen, right? And that can be broken into a lot of different parts. So first is we need better insurance. Fewer people without insurance, fewer uninsured people. Obviously, that's hard. We've been having a fight about that for many, many years. That will likely to continue. But so one part of, well, how do you make this less of a burden is you give people better insurance. The question is who pays for that? I'm not going to get into that. I'm just going to tell you that, look, if you want to solve this particular problem, this is one way to do it. The other, of course, another way of dealing with it is to say, well, look, you don't need insurance, you just need more savings. Right? We need to help educate people on the value and provide vehicles for them to increase their savings. Of course, the problem is that many people don't make very much money and it's hard to save. So that's maybe a little bit utopian, but certainly it is a feasible solution to help people be prepared. And then last, and this is just kind of effort, we need people to be more prepared, right? So I always like to say, I always joke that patients are idiots, right? And I feel okay saying that because I would put myself in the idiot patient category, right? And patients are idiots not because they're literally dumb, but if they're inexperienced. Most patients, you get a cancer diagnosis, it's not like, oh, I know what to do, right? Or any diagnosis, I don't know what to do. Like I'm not an expert, right? I'm inexperienced, right? And so we lack the literacy to be empowered to make real good choices, right? And, just to give you some of the sense of the baseline that we're dealing with, right? So one survey recently tried to get people to describe an insurance deductible. Only 42% of Americans can accurately describe an insurance deductible, right? So if I don't know what a deductible is, and it's a big part of how we're going to try and manage the cost of care, we might have some problems. Another different survey said, well, would you like to talk to your provider about the cost of what you're getting treated for and maybe make decisions kind of based on cost? 50% say, yeah, I'd love to have that conversation, but only 19% actually follow through, right? They don't feel comfortable or empowered to have that conversation. It's not brought up in a way that allows them to do it. Lastly, more than 25% have given zero thought to what they want their end of life to look like. And we'll talk about end of life care here in a minute, but that matters. right? So we have some work to do in making sure that we as patients, when we interact with the system, have some clue, have some power and some knowledge to actually maybe make some better or different choices. Okay, so these are things that we might do better to be prepared for the shock. But of course, the ideal thing is just to reduce the size of the shock, make it easier. So that means basically we want to lower spending. So how do we do that? Well, spending is a simple formula. It's the cost per patient times the number of patients. And well, what's the cost per patient? Well, that's just the price per treatment times the number of treatments. It gives us 3 variables that we can work with. Basically, so we want to lower spending, we can lower the price of each unit of treatment, or the average price of the set of treatments that you choose. We can eliminate unnecessary or inefficient care. Or, of course, we can just not have people get cancer in the first place, right? That will all reduce the level of spending on cancer care. So, well, great. How do we actually do this? So how do we lower prices? If you've ever endured a principles of microeconomics class, you understand this little X thing on the left. If you don't worry about it. It's just a convenient way of, the economists basically say, well, look, if we want to understand why prices happen in a normal market, we drive this thing called the supply curve. And we think the supply curve is really just a function of the cost of producing whatever it is we're supplying. And then we have a demand curve, and that's basically a function of the value of it. And then when these things intersect, that gives us the price. So then if we want to change the price, well, what do we want to do? Well, we want to change the cost of production and delivery. And so let's make it cheaper to create new drugs, right? Make the approval process easier, or whatever it is that we might do. Or maybe it's the doctors who are the problem. We want to make it cheaper for, so if medical education is cheaper, they don't have so much debt, maybe they don't need to ask for as much money. Or maybe we can get rid of administration costs, right? Because we have all these insurance providers and it adds this, big tax. Maybe we can do something there. Or of course, maybe we can just change the mix of ways that we provide treatment, right? So we can sub out the MD and replace them with the PA or the RN or something like that. We can change the mix of inputs and use cheaper cost ones, right? So those things all, if we can do them, might lower the cost, maybe a little bit. As we'll see on the next slide, there's some things that might be kind of impede them. So what can we do on the demand side? Well, look, I just showed you that healthcare, treating cancer is really valuable, right? So if it's effective, I'm going to keep paying it, right? The challenge for us is that, well, maybe not all of it's effective, right? And maybe we're not actually making choices based on the actual value that we're getting from whatever treatment is, right? So perhaps we can help this with greater price transparency. So as a patient, I actually know what this thing that I'm going to do is going to cost, which is not a common thing. It's becoming more common. But of course, just knowing price isn't enough, right? Actually, so economists like me have been saying price transparency for a long time. And there's a healthcare reporter that I follow who, even wrote this wonderful article where she's like, I need an MRI, and I shopped around and got a lower price. It was like 1/3 the price of this other one, and I'm feeling great, right? And then of course, time goes by, and it turns out that the cheap MRI, actually there was a quality difference in her particular case. Usually that's not the case, but in the rare thing that she had, the expensive MRI was actually necessary, so she ended up having to go back and eat crow and get the thing. So we actually need to know both price and effectiveness and quality for price transparency to work. And there's ways that we can kind of help where we know that kind of stuff. We can use things like reference pricing. Reference pricing is where there's a certain category of drug or whatever it is, and basically the insurance company says, we will pay for any drug in this category this amount of money. And if you want something else, you pay the difference, right? That's a way of trying to steer people to things where we actually have evidence of effectiveness. But of course, this requires us knowing effectiveness, which is frequently not something we do. But of course, this isn't actually a great way of thinking about healthcare markets. Part of the reason people like me end up doing healthcare economics is because it's actually more interesting than that. Because this actually doesn't really apply. There's all sorts of things that we call market failures. I won't get into them, but the challenges in healthcare are many. So that limits the power of market-based solutions to actually lower price, right? So if we want to lower price, that means we have to do other stuff, right? So what can we do? Well, we can just regulate the price, right? We can just say, we will not pay more than X, right? You can not regulate, but you can say, have a single payer system or allow all payers to negotiate together, which basically increases the buyer power. So right now, particularly on, say, a drug price, we grant a patent. We basically say, you created something new. You're now a monopolist, right? Well, monopolies charge more money. That's what they do, right? So we can basically counter them by saying, great, you want to be a monopolist? We'll be what's called a monopsonist, the single buyer. And now we just have to negotiate the price down to whatever we want to. The other thing we can, of course, do is just not give out patents in the first place, or otherwise reduce provider market power. Now, of course, whenever people like me say, okay, you can do these things, you get this thing, well, you're going to kill innovation, right? We kind of accept it in the US, because in the US we pay about twice as much per capita for healthcare as other developed countries. And basically this is our, well, this is the tax we pay to subsidize the development of all the treatment. And so, great, but so if we try and reduce the amount that we pay, then there won't be any money to fund innovation and we'll all be worse off because we won't be coming up with the things that have allowed us to increase 5-year survival rates by 16%, right? So what do we do there? So my half-baked idea, this is Bryce's half-baked solution, is I don't know why we don't fund drug research like an X Prize, right? Like say, look, if you can achieve a measurable change in X, we will pay you billions of dollars, right? But then, after that, the drug becomes a generic, right? The molecule becomes freely available worldwide. So to me, this is the way that we should try and do this. Then we can kind of save on some of the expenses we currently have on Me Too drugs, or people trying to patent and then market drugs as being something that they're really not. So we have this whole effectiveness issue. Well, maybe we try and deal with it this way. I'm sure other people have thought about this and come up with reasons why they shouldn't do this, but this is what I thought of when I was a graduate student, and I still haven't been convinced that it's not the way that we should fund, particularly some types of cancer research. Okay, so that's prices. It's hard to deal with, obviously, but it's a lot. We could make a lot of money, or save a lot of money if we could somehow move the needle on prices. Of course, we have work to do on quantities, kind of across the healthcare system. The standard estimate is about 1/3 of all healthcare doesn't actually produce health. So there's lots of things that we can kind of we could maybe reduce. And if we could do that, that would lower costs. Well, how do we end up with this 1/3 of healthcare that isn't actually producing health? Well, generally it can be traced back to one of two sources, either incentives or ignorance, right? So on the incentive side, we have patient incentives, right? So if you give me insurance, right, particularly very generous insurance, I don't pay the full cost of care. So perhaps saying at the margin, I'm like, yeah, I'll take that test, I'll take that treatment, do whatever, right? And it's not actually being driven by actual value or effectiveness to me, right? We call this moral hazard, and it leads to overtreatment. So of course, the natural solution is to say, well, look, let's make patients put more skin in the game. Let's raise deductibles. Let's increase copays. Because if we do that, well, patients will make different decisions, and they will, right? If you make patients pay more, they consume less. We have seen that time and time again. The challenge, of course, is what do patients consume less of, right? Are they informed enough to actually ration their care efficiently? And to do that, they need really good information about the effectiveness of whatever they're trying to do, which means we actually need to know about the comparative effectiveness of different things. There's different kind of value-based insurance design, which is where your deductible changes depending on what you're doing, or again, reference pricing can help deal with it on the patient side. There's probably some margin where we can make a difference by changing patient incentives to help squeeze out care. We also have issues with provider incentives. So a survey by some guys at Johns Hopkins, they surveyed a bunch of doctors, and 75% of doctors believe that other doctors order extra tests and procedures because it increases their income, right? This is my favorite quote, but we've seen this in other studies. We found other studies where you can kind of see these margins of people who clearly, at some margin choose to order something or do something, likely because it increases their income. But it's not just providers. The drug companies are also kind of annoying. So this came out a couple weeks ago. Drug companies make eye drops too big, and you pay for the waste, right? So literally, the size of a standard drop from an eyedropper is twice as big as your eye can absorb. That's a magic money machine, right? So that's eye drops, right? But what about cancer drugs? Well, a lot of cancer drugs come in single vial uses. The dose depends on how big you as a person are, right? Right? So you, or maybe a small person, don't use the whole vial. Guess where that $9,000 vial goes? into the trash, right? So once they just looked at the 20 top single vial cancer drugs and found that 10% of all of those drugs were wasted, that's $1.8 billion literally into the garbage. 1.8 billion is like 1.5% of total spending on cancer, right? Literally thrown into the garbage. Why do they do this? They'll give you some BS explanation, but it's mostly because they have an incentive to do it, right? Okay, so those are incentives. Obviously, if we could work to improve incentives by, not letting people throw drugs that are valuable into the garbage, maybe providing value-based repayment for providers. Okay, so there's incentives that we can work on. There's also ignorance. We have ignorance issues. There's a whole array of treatments, lots of different evidence bases. This is actually going to work? Is it going to work for me? And is it actually going to work enough to provide enough value that it's going to pay off? Those are really hard questions to answer because usually when you do a study of this stuff, well, you have an average, right? But there's a distribution. And well, maybe I'm the guy over here for whom this is going to work really well, right? And it's really hard to then make evidence-based decisions because the evidence base isn't the evidence. It's not like we cloned you and tested a bunch of drugs on you and said, oh, yes, for you, this is how this drug will work, right? We don't know that, right? So we have a lot of ignorance. There was an article in the New Yorker recently by an oncologist, and the metaphor he used, which I loved, he talked about, he started the whole thing talking about zebra mussels. You guys familiar with zebra mussels? They're these things that are taking over the Great Lakes. Right? Now, the zebra mussel is native to something like the Ukraine or something like that. And in its native habitat, it's just a normal thing, right? But you drop a zebra mussel into the Great Lakes, and it literally takes over, right? He was basically using this as a metaphor for metastatic cancer. We don't know why cancers metastasize in particular people in particular places, right? We kind of think that the environment matters. But in some sense, it's just like we don't know why the zebra mussel actually survives so much better in the Great Lakes than it does in its natural habitat. We have some ideas about the environment, all that kind of stuff. But in terms of actually kind of creating the matrix of person, cancer, odds that this metastasizes, odds that this treatment will solve it, or this treatment, or this treatment, or this treatment, that's really hard, right? So part of our problem is just that we're too ignorant. We don't know enough yet. We have a lot of work to do to kind of, as both patients and providers, know more so that we actually don't end up treating you in something that literally won't work for you. But we didn't know that at the time. So some of the byproducts of this ignorance, one is we end up with overdiagnosis and treatment, right? So many cancers aren't going to kill you, right? But we can detect them. Right, so what this little thing says is, okay, look, we have an abnormal cell, and then at some point, as we move down time, we get to the dotted line, and we detect that you have this cancer, right? Well, if it's a really fast cancer, you're going to get to symptoms and death pretty fast. But if it's a really slow, the snail cancer, you can have that cancer for a long, long time, right? The challenge is that when you are told that you have cancer, many people freak out, right? So Atul Gawande, in a different article in the New Yorker, so Atul Gawande is one of my favorite healthcare writers, but he's also a surgeon, and he tells a story about a patient, right, who had a micro tumor in her thyroid. And it's basically like, look, this is snail cancer. Actually, he used tortoise and hare in the thing. So this is hair cancer. This is very unlikely to cause you any problems, right? This surgery has risks, right? Basically trying to say, patient, you've been diagnosed, you've heard the cancer, you're freaking out about having cancer, but I'm here to tell you that this cancer is just not likely to kill you. So maybe just let's just manage it, watch it, don't go through this surgery. Of course, the patient, being a normal human, hears cancer and freaks out and says, yeah, I want the surgery. Ends up with side effects, ends up with more costs, right? So we have to learn about the difference between which cancers are actually the scary ones and which cancers aren't, right? And that's part of educating the public and educating patients that when you hear cancer, when you hear that you have a tumor, okay, well, really, what's my risk here? We also have futile care, right? So this graph is the spending on people who have died, right? So obviously, in months of diagnosis on the horizontal axis, spending is on the vertical axis. And of course, right after you get diagnosed, you're spending a lot of money. But then it goes down. And then depending on whether you die at 36 months, 60 months, 72 months, or 96 months, right before you die, you start spending a whole lot more money. All right? Now, of course, I don't want to say, look, we don't know if you're going to die, right? But some amount of spending in these last months is certainly not effective. And in fact, frequently we know it's actually not even what patients want, right? But they're not having the right conversations. They're not communicating well enough to say, yeah, let's move to palliative care. Let's move to hospice. Let's move to something that isn't as, amongst a lot of patients, they spend 21 days of their last 60 days of life in ICU, right? It's not a great way to die, right? Most people, if you ask them, do you want to die in an ICU? They say, no, I want to die at home, right? But we end up spending a bunch of money at the end because of a variety of reasons. But this is one area where we can try and do better to squeeze down Q. All right, so the other thing, last thing we can do, of course, is incidence. How do we reduce the rate at which people have cancer, right? Well, of course, we can get people to not smoke, and there's various health behaviors that we know are bad from a cancer perspective. And then we want to reduce exposure to maybe pollution or different things that might also cause cancer. The problem is, of course, again, what is it that causes cancer? What is it that causes cancer in me? And this is one of my favorite illustrations of this. On the horizontal axis, basically, if you're to the right of the line, that means that you cause cancer. If you're to the left of the line, you protect cancer. And then we have a bunch of different food, and each dot is a different study. What should you eat to be safe from cancer? I don't know, right? It's hard, right? We don't have a good evidence base again. And even if we configure this kind of stuff out and we can maybe do a better job, we still have a challenge. So this picture, this is my grandfather. He died in 1968 at the age of 47 from a heart attack, right? If he lived today, he would not likely die from that heart attack, right? We do a much better job of treating heart disease. He still would have lived and would have died of something, right? And so here we have the death rate from heart disease and cancer. Heart disease, hey, it's getting better. We're doing a good job. Cancer's going up. What's going on? Well, the people who used to die from heart disease now die from cancer, right? So we can do a good job of treating lots of different things, but eventually you die, right? And so you're going to die, and frequently cancer is what you end up dying of. So we have obviously we want to do better. We want to reduce cancers that we know we can reduce. But we're unlikely probably to get rid of cancer altogether, but maybe we will. Maybe we'll get lucky. So at that point, I will now stop, and you can ask me questions if you have any.
Anybody have a question? Chelsea.
I apologize for stepping out if you already addressed this, but it seems to me that a lot of people who are given a cancer diagnosis of any kind at this point resort to the GoFundMe economy in order to get through their treatment, and then of course pay for living expenses during treatment and after treatment. I personally, and I know Leah talked about this, both had GoFundMe accounts set up, and I don't have enough money to pay for all the cancer treatments that my friends end up needing as they go through their lives and more people are diagnosed. Do you have any insights that you might point out about this trend in funding your chosen family's healthcare through
Yeah, I mean, look,
donations?
on the one hand, it's nice. Obviously, anything that brings us together and allows us to connect with other humans is something that, I don't want to discourage. But the reality is it's not uncommon, particularly amongst, people in that middle income and lower income bracket. An enormous percentage of them say they have to borrow money from somewhere to pay for care. So on the one hand, it's great that technology makes this easier, right? Because you can imagine before the GoFundMe world, how did you get the word out, right? How did you, have a platform to extend to a bunch of people who might chip in a little bit? So great, it exists. The bigger question is why does this need to exist, right? And is this, and that's a social question, it's a political question, right? Like, if you are diagnosed with cancer, is this a social cost that we collectively bear as a society? Or is this a private cost that you, depending on your social network and your social capital, bear either individually or with help from whatever the size of your social network is, right? And those are that's what literally what we've been debating in Washington, right? Is this a social thing or is this a private thing? And that's obviously philosophical and personal. But that's we need to actually, in my opinion, we need to actually have this conversation in rooms constantly. Let's fight it out and just decide, is cancer, it doesn't have, look, we don't have to, or certain cancers, right? Because a lot of times it's like, we have this notion of the undeserving sick, right? Well, you smoked. It's your fault. Why should I pay for it? But certainly that does not apply to a lot of cancers, right? It's like, well, why did I end up with this? Right? Well, as far as we know, it's truly exogenous. You lost the genetic and environmental lottery, right? What do we want society to be? Do we want people to pay for that collectively, or do we say, screw you, sucks to be you, right? That's our choice, though. But it's why we get to, we live in a democracy, right? Is we get to have that discussion, and not really, but in theory, that's what we do.
Yeah, could you go back to your last slide? Yeah, that's the incidence of the cases, right? Not the death rates.
And this is deaths, right? Number of deaths.
Because actually, as far as if you look at the top 10 causes of death, cancer in Montana has actually surpassed heart
I think
disease.
it's cut off.
Right. No. But in the United States, it's still that way. But we've actually been doing better as far as overall treatment, and actually most of it falls into where we've done a lot better, where you're talking about things, is prevention has made some of the biggest changes in the overall rate. So if we look at the top 10 causes of death, most of them, suicide sadly not, are actually going in the right direction. Of course, we still always have to have a top 10.
Yeah, no, we're always gonna have a top 10, and essentially the point, and I looked for a different graph. I wanted to show you basically, it used to be infectious disease, that's what killed you, and then we moved to heart disease, and essentially we've now moved to cancer, and we're gonna make progress on that, and apparently we're just gonna kill ourselves. Like that's, I don't know if that's the progression that we want, but that's the trend. So, over here.
You had mentioned that we spend twice as much as many other developed countries per person on healthcare. And then there was also sort of a comment about that's the cost of innovation maybe. Is there actually an economic analysis that you can speak to that what does that extra
Money
doubling
buy?
of costs go towards?
Well, mostly it goes to pay for doctors, right? That's the biggest chunk of it, right? But it also goes to, we pay more for every, it goes to all the, but a lot of it does go to pharmacy companies, it goes to medical device providers. Just thinking about an MRI, right? Like an MRI in the United States is like, frequently 3 to 4 times as expensive as someplace else. And there's of course variation even within the United States on that. So where's that going? Well, it goes to the radiologist and it goes to the people who, put the MRI there. They collect some, and also goes to the device manufacturer. Our doctors make more here. Plain and simple, doctors make more. Other parts of the medical system, basically every part of the medical system earns more here in general. I don't know if that's truly a fact, but in general, that's generally true. So it's everywhere, right? Which is why it's really hard to squeeze it. Right? Because it's basically, we say, hey, we want to reduce the price. It's like I can get, oh look, hey, it's just a simple formula, right? Like it's P times Q. Like let's just do that, right? It's real simple, right? Well, my spending is somebody else's income, and those whose income it is tend to fight back, and those whose income it is are 1/6 of the economy, closing in on 1/5 of the economy, right? So it's not easy to then go, yeah, we're just going to take money out of your pocket and put it in my pocket, because that's really what we're doing, right? Particularly when you're basically saying, oh yeah, what you're doing is really valuable, right? It's really important what you're doing, but I just don't want to pay you as much, right? That's the conversation ultimately that we're stuck on. All right, oh, somebody's frantically waving their hand. We want to let them.
One last question.
This previous question. So do you have any estimate of what is the cost of for-profit healthcare, and how much goes into stockholders' pockets from the NASDAQ and the Dow, where most insurance companies, pharmaceutical companies, the manufacturers of radiologic equipment, all of that goes.
Yeah, so pharmacy companies, they're not actually that profitable. Insurance companies are not actually that profitable. Pharmaceutical drug device, they tend to be pretty profitable. Hospitals, it's kind of a mixed bag. In general, when we compare for-profit and not-for-profit hospitals, there's some minor differences in terms of, the for-profits tend to concentrate on things that have higher margins, but overall they tend to be pretty similar. So there's not a huge difference in, how you organize a hospital in terms of the care it provides or the cost of it. Mostly where you see profit in the system is in the research thing, but of course then that's part of this innovation discussion, is because then that's supposedly what funds then the next risk-taking venture. That's roughly my impression, although I haven't done a drill down on it. All right.
Great, thanks, Bryce.